Hello, welcome to another episode of EndoTalks. Today we're discussing delaying or eliminating stents in advanced esophageal cancer. And I'm thrilled to introduce our guest, Dr. Prasad Iyer, who is a professor of medicine at Mayo Clinic, Rochester. He's also director of their esophageal diseases section. And more importantly, for today's discussion, he has a special interest in treating esophageal cancer in Barrett's esophagus. So welcome, Dr. Iyer.
Hello, Dr. Siddiqui. It's a pleasure to be on with you. Thank you for the invitation.
No, I'm excited to get into our discussion today about how you're using liquid nitrogen spray cryotherapy to treat esophageal cancer patients at Mayo Clinic.
This is a technique that has actually been around for several years. We at Mayo Clinic have been using this technology, I would say, for probably over a decade. The technology has gone through some iterations, but essentially it involves spraying liquid nitrogen through a catheter, which is advanced through the biopsy channel of a diagnostic endoscope onto target lesions. And when liquid nitrogen is sprayed and exits the catheter, it basically produces a temperature of minus 196 degrees centigrade and allows the tissue to be frozen. And because the gas expands significantly once it is sprayed, there is also the need for a decompression catheter to be placed alongside the endoscope into the stomach. So there is continuous suction during the spray. Typically, the technique involves freezing for about 20 to 30 seconds, followed by a thaw cycle of approximately 60 seconds. And this freeze thaw cycle is repeated approximately 3 times, depending on the target lesion that you are treating. You could also go up to 5 times. There is some flexibility in terms of how long the freezing cycle can occur as well. For advanced cancers, if you're palliating this, you could go to 30 seconds as well.
And the mechanism of action is cellular death?
The mechanism of action is basically causing cellular necrosis by this freeze-thaw cycle. So essentially, the cells are frozen, and when they thaw, the cell injury begins to set in. The other important thing, as you said, for the mechanism to note is that because of this freeze-thaw cycle, most of the damage is limited to the cells and not necessarily to the stroma. So the stroma is usually preserved. And the second mechanism of action is an element of an immune response. Because the cells are being necrosed, some translational studies have shown that there is a T cell immune response. So there is this initial damage, and then there is subsequent damage over weeks from an immune response that follows as well. So these are the two components which allow the treatment to be effective.
And I'm sure for a lot of our listeners, they're familiar with cryotherapy used in the treatment of Barrett's esophagus historically. And, there's the 2 different types of delivery, whether it's the spray versus the balloon. So what advantages does the spray system have in the setting of cancer palliation?
Yeah, no, that's a great question. So just to take a step back, the second modality of cryotherapy that you're referring to is the balloon cryotherapy. So it's different in a couple ways. Number one, it uses nitrous oxide as the cryogen. The temperature it produces is actually a little bit higher than liquid nitrogen, so the freezing is not as intense. The third difference is that unlike liquid nitrogen, which is sort of sprayed at the lesion and sort of diffuses into the stomach, in the balloon cryotherapy technology, everything is contained within the balloon. So you don't need a decompression catheter. And perhaps very importantly, which is sort of an advantage for liquid nitrogen, is that there is no need for specific contact with the lesion. Unlike with a balloon, where you have to sort of make sure that the balloon fits inside the esophagus and is in contact with the mucosa, here you don't have that need. You can actually be a few millimeters away from the lesion and actually spray at the lesion.
Okay, so obviously in situations where you have malignant strictures, perhaps this is easier to get treatment on the cancer area.
Yes, in several respects, that is one thing. The only thing to note is that you have to have enough space to put your endoscope in, which is a diagnostic endoscope, and then you also need a decompression catheter to be alongside it. But you don't need contact with the lesion.
Okay. And then can you tell us a little bit about your research using liquid nitrogen cryotherapy in cancer patients?
Absolutely. I have to give credit to our fellow, Dr. Hanada, who actually led this study. She is actually now a therapeutic endoscopy fellow at the University of Colorado in Denver. Dr. Hanada looked at our experience of treating patients with esophageal cancer who had either failed or were not a candidate for any other endoscopic therapy. They were about 56 patients, and all of them received liquid nitrogen spray cryotherapy, and we followed them forward in time and essentially looked to see what were the outcomes, particularly in terms of avoiding or needing an esophageal stent placement. As you know, Dr. Siddiqui, many of these patients, if they are not candidates for chemotherapy, radiation, or surgery, for a variety of reasons, will experience a significant amount of dysphagia, which compromises their nutrition. And oftentimes they end up needing a stent placement. And stents, as you know, are certainly can help patients, but they are also associated with pain. They can be associated with perforation. They can slip, and of course can cause fistulae. So our intent was to see, are we able to avoid or maybe even delay the institution of a stent placement in these patients? So over a follow-up of about 2 years, these patients received several rounds of spray cryotherapy, typically about 2 to 3 months apart. And what we found was that at the end of a median follow-up of about 24 to 25 months, only a quarter of these patients actually needed a stent to be placed. In the remaining patients, we could actually avoid stent placement, maintain their quality of life, and avoid any nutritional compromise.
Were these patients a little bit lower stage and you were using it more to prevent progression? Or was it more bulky tumors that you were trying to decrease the size of tumor burden?
I think a combination of both. Some of them were actually early stage tumors, which were not responsive to endoscopic therapy. And the patients either could not or would not undergo esophagectomy for a variety of reasons. And we were trying to prevent the growth of the tumor. There were some who actually came to us with advanced disease, again, for palliation, really. And in these patients, we actually ended up dilating the tumors somewhat to allow spray cryotherapy to be initiated.
And did you notice any change in survival rates by, in these patients compared to historical cohorts when you just do palliative stenting?
Yeah, we unfortunately did not look at a comparison. I think our primary outcome was really number one, the need for stent, and number two, complications. These were sort of the two main outcomes. However, there have been other studies in the literature which have actually looked at spray cryotherapy alone or even as an adjunct to chemotherapy and radiation, and shown an improvement in response or a prolongation of at least stent-free survival.
And you mentioned the complications. What kind of complications did you see, in your
Yeah.
study, and what do you warn patients about?
Absolutely. I think that's very relevant. So that was our main secondary outcome in this study. So the most common complication was stricture formation, and that occurred in about 25% of our patients. And it is important to remember that some of these patients actually came to us with a stricture. So In that instance, we would do gentle dilation, and most of the patients could continue with treatment. So stricture is number one. 2 patients out of 56 actually had a bleed, which required hospitalization, but was able to be controlled. And there was 1 perforation, which was sort of at the beginning of this treatment.
Okay. I guess one of the discussions always is, what can we offer a patient endoscopically? And as you mentioned, in these esophageal cancer patients, typically esophageal stents are offered usually late in the course of disease. And at our institution also, we never place stents early because of all the things you mentioned. They migrate. We've had a few cases of fistulae, bleeds from erosion into vessels. So we definitely don't have great options. And so is liquid nitrogen becoming more standard in, these refractory esophageal cancer patients at Mayo Clinic? Is it something we should be using more?
Given I would say this is a tough group of patients because they don't have too many options. And I think if you look at the overall safety profile and the effectiveness of this treatment approach, I would feel that this should perhaps be offered ahead of a stent placement. And at least at our institution, when we get referrals from oncology or we are seeing these patients ourselves, we like to try this before we decide to place a stent and see if we can actually delay stent placement, or maybe in some instances eliminate the need for a subsequent stent placement.
And when we place stents, if a patient's had prior radiation therapy, for us, it's always a red flag. This patient's going to be at increased risk for fistula formation. Is that a concern with liquid nitrogen therapy?
We did not observe that in this study. And in fact, there was an analysis done to see what predicts strictures, because strictures were sort of the most common adverse event in these patients. And prior chemotherapy and radiation was actually not a factor which predicted stricture formation.
And in your experience, do you notice that you have better or quicker palliation with the liquid nitrogen spray compared to, say, radiation in terms of symptom improvement?
I don't know if there has been sort of formal evaluation of this, but these treatments take typically a couple rounds to work. So, and these patients come back every, I would say, 6 to 8 weeks apart. So you would need several weeks before you would see this happening. And unfortunately, many of these patients are not even candidates for palliation because for palliative radiation, because they've already maxed out on the radiation. So I think that's a tough concept to study, but typically you would need 1 or maybe 2 treatments for a response to be seen.
Could you potentially do them closer together, or do you want to wait that full 6 weeks to see the full effect of the treatment that you applied?
Yeah, that's a great question, and I don't know if that has been adequately studied. We like to wait at least 6 weeks because, at least in some of the instances, we brought them back sooner. There's a lot of ulceration that is still residual from the prior treatment. And for safety purposes, we avoid treating patients with a lot of ulceration just because you're spraying this at high pressure and you don't want the gas to sort of track into the mediastinum.
Let's say I want to start, offering this therapy to my patients. What kind of things do I need to consider other than, okay, I have to buy the equipment? In terms of training, what's the learning curve? Is it difficult or easy to use?
Yeah, I would actually say in terms of setting up this kind of a practice, you probably need to have a good collaboration with your oncologists, because those would be the patients that, particularly as you want to treat more advanced cancers, you would want to have a referral line built in. So I think that would be a first component. Um, Engaging with them and making them aware that this kind of an option is available. That's number 1. Number 2, in terms of training, the learning curve is not particularly steep. I think there has been a paper published in the literature where I think you don't need more than like 5 to maybe even 10 cases to get really comfortable at this. The company, I believe, can provide some training. There are courses where you can actually get hands-on experience with this as well. And technically speaking, I think the more important, just because of the way the treatment is delivered, you don't need to be in contact with the mucosa. I think case selection is important, and maybe getting some training at the initial end would be sufficient in my mind.
Okay. And when you're doing the actual procedure, obviously you mentioned putting down the nasogastric suction tube, which is very important. That's just kept to low intermittent suction throughout the procedure, I assume.
Yeah, so it's actually an orogastric tube.
Or, sorry.
There is actually a high level of suction, and the suction is actually provided by the console itself. So it's different from the wall suction that we have when we are doing endoscopy. So this is a higher level of suction which the console itself provides, and it's continuously sucking out the liquid nitrogen as you are spraying. So that's a very important thing. And in fact, there are two things that you do. You have the suction on, and then just to be sure, there's an assistant who has their hand actually on the abdomen to make sure that there is no sort of undetected distension that might be happening during the spray.
And when you're actually applying the spray, you're, as you mentioned, the multiple, freeze thaw cycles. Do you just try to cover the whole area and just under visual inspection as you're doing it?
Yeah. So that is one of the, I don't think this is particularly standardized. So I like to treat quadrants, and I would just do a fourth, a fourth, a fourth, a fourth, if that's how the way you would do it. As you are spraying, you will actually see the freeze kind of not remaining confined to a particular quadrant, but that might be one way of starting it. Or look at third, something like that. So you would want to treat a particular site at least 3 times, and then move on to another site, and then move on to another site.
Is there any increased incidence of complications if you overtreat an area?
Yeah, so animal studies were done at the beginning of this, and that's how this 20-second freeze and 60-second thaw was determined. And the depth of injury is typically into the deep mucosa and superficial submucosa at this level. If you keep freezing for longer, you have the potential for going transmural as well, so you don't want that.
Okay. And
now, if you're treating a very bulky tumor, you could go up to 30 seconds, but I haven't seen anyone recommend or go above that.
And do patients have any increased symptoms of dysphagia immediately after the therapy from, say, edema or swelling?
Yeah, for a couple of days, that can be the case. It's fairly well tolerated. There can be some pain, but actually cryotherapy in general causes less pain than thermal technologies of ablation. So patients do very well. And we do warn them about watching for this higher dysphagia, and we might put them on a liquid diet for a day or two before they begin to advance.
Okay. Are there any other instructions you give them when you send them home?
Not really. I think the pain is one issue. Watching for the dysphagia is the other issue. Obviously, other complications like bleeding can certainly happen down the road. You would detect anything else like a perforation or something right away. And we only had 2 episodes of bleeding in this patient, in this case series that we looked at.
And then at Mayo Clinic, are you using the liquid cryotherapy for other applications currently?
So we are using this for patients with Barrett's who are not Barrett's high-grade dysplasia, low-grade dysplasia, who are not responsive to maybe first-line treatments. We actually had a systematic review and meta-analysis that we published earlier, where we found that in those who are refractory to standard treatment, liquid nitrogen spray cryotherapy is effective in up to 60 to 70% of cases. So that's one population where we are using liquid nitrogen spray cryotherapy. We have also used it for squamous cancers, again for palliation, or maybe even early stage right after resection of treating residual dysplastic tissue. those are some of the indications we've used this for.
All right. And again, in your mind, the advantage with the liquid spray is the non-contact applicability of it. So that makes it a little bit easier to treat an area.
Absolutely, particularly if the esophagus is distorted, it's scarred, it's uneven. That's one. Second is it's tolerated very well in terms of pain, and the incidence of bleeding is fairly low. And in fact, if we are faced with an instance where we cannot stop anticoagulation in patients, then cryotherapy is actually a little bit better. It tends to cause less bleeding than thermal therapies.
Oh, so you have been using it in patients who are actively on blood thinners.
Yeah. A few patients. That's if we have to pick between cryo versus say a thermal therapy like radiofrequency ablation. I think the cryo is something that we would probably prefer first.
All right. I think you've made quite a few great arguments as to why perhaps liquid nitrogen cryotherapy could be a great addition to our endoscopic toolbox when we're dealing with these cancer patients and perhaps also dysplastic lesions in Barrett's and squamous cell. If you had a few final thoughts on liquid nitrogen cryotherapy, hopefully you'll share them with us now.
Yeah, thank you. I think as you rightly said, in a unit which is focusing on esophageal endotherapy, I think liquid nitrogen spray cryotherapy is certainly one of the tools that I would suggest be part of the toolkit or your armamentarium. Second, I think patient selection is very important in terms of who you actually treat. Third, I think getting adequate training and maybe some proctoring at the initial end is important as well. But as studies have shown, the learning curve is not as steep as some of the other technologies. And lastly, I think it's very well tolerated by patients as well.
I think those are all great points, and especially, the multidisciplinary approach to get the oncologists and even your surgeons on board with offering this as an adjunctive therapy. And I'm excited to hear you've offered to proctor me in my first cases of liquid nitrogen cryotherapy. But I think you made a very compelling case for this kind of treatment, and it's something that we should all potentially consider if we're handling and seeing these types of patients. So
Absolutely.
thank you.
Thank you.